Hello, my name is Patrick Salibi. I'm one of the HPB fellows at Carolinas Medical Center in Charlotte, North Carolina with Atrium Health. I'm going to be presenting the Japanese difficulty scoring system and how it correlates with postoperative outcomes better assessed by the Comprehensive Complication Index in our patients undergoing MIS liver resections. MIS liver surgery was initially slow to get picked up, first reported in 1994. It wasn't really until the 2010s when we saw a more rapid increase in interest with growth in technology and the increasing ability to digitally share approaches and techniques. So the question then became is how to determine what is safe in MIS liver surgery. As I noted, it was first reported in 1994 when the first laparoscopic liver resection came out in the literature. It wasn't until 2008 that a group of what was felt to be expert surgeons at the time came together at the Louisville Consensus Conference and put out the Louisville Statement, essentially giving guidelines to surgeons what was considered to be safe in MIS liver surgery for novice, intermediate, and expert surgeons. These were updated in 2015 at the Morioka Consensus Conference, and then again in 2018 at the Southampton Consensus Guidelines, using the most up-to-date literature in order to help guide surgeons on what was safe in MIS liver surgery. Difficulty scoring systems were also put out around the same period of time to help surgeons determine what was safe and efficacious for an MIS approach to liver surgery based on resection-related factors. The goal was to help guide surgeons based on their skill level to determine if it was safe to proceed in an MIS fashion, and then hopefully secondarily correlate with these difficulty scores with postoperative outcomes. One of the original scoring systems put out was by Ban et al. And it actually used a system that scored tumor location, size, proximity to major vessels, liver function, and then extent of resection. And then based on the total number, classified surgeries into tiers, giving surgeons guidance based on the number of cases they had performed and their overall laparoscopic skill as to whether or not the surgery can be performed safely in an MIS fashion. Numerous of these scoring systems have been developed and updated since, as you can see here, and they have also been validated with one of the larger validation series by Tanaka et al., validating the Ban et al. Experience in both the Japanese cohort, stressing the accuracy of these models in predicting intraoperative outcomes such as blood loss, operative times, and conversion rates, whereas being a little bit less reliable and being able to predict postoperative outcomes between groups. As you can see here, there was no significance noted in between the low and intermediate groups. This held true when Tanaka updated their validation based on the WATA criteria, which updated their original difficulty scoring system. And they found when comparing either between Japanese multi-institutional cohorts or a French cohort, that again, there was accurate intraoperative predictions, but it was less reliable for predicting total postoperative outcomes between groups, as noted here in their postoperative complication percents by tier. Lee et al. Attempted to do the same with the BAN's difficulty scoring system, comparing a Singapore cohort combined with a New York Memorial Sloan Kettering cohort. And again, they found accurate prediction for intraoperative outcomes with significant differences across the board in regards to operative time, conversion rates, and blood loss. But when looking at postoperative morbidity and mortality, while there was a significant difference in mortality, there was no difference in morbidity noted when comparing by highest graded postoperative complication. So the question then becomes is there a problem with the complication grading system? Most of these studies used a classification system similar to the Clavian-Dindo complication system, or used the Clavian-Dindo complication system, which is a 5-tiered system grading postoperative complications based on the severity. It was initially put out by Clavian's group out of Zurich in 2004, and it continues to be widely used in the surgical literature. Their group updated their complication model in 2013 when they published a paper looking at the Comprehensive Complication Index, which used the Clavian-Dindo grading system, but developed a formula that gives you a continuous scale that ranks the severity of the combined complications from 0 to 100 for a single patient, and weights each of the severities and gives you a number between 0 and 100, with 100 equaling death. So complication classifications, when comparing the two, the Clavien-Dindo classification system usually only reports the highest complication occurring in the postoperative period, while the comprehensive complication index gives you a better picture of the overall complication burden that the patient experiences postoperatively. Based on this, we felt that the CCI was likely a better model for postoperative complications and might better correlate with the difficulty scoring systems developed for MIS liver surgery. So our institution looked at a retrospective query of our surgical registry for hepatic resections that were performed over a 12-year period from 2008 to 2019. We included all pure laparoscopic and robotic hepatectomy cases, and then we wanted to assess whether or not the difficulty scoring system could accurately predict postoperative complications when graded by Clavien-Dindo alone and the CCI. We had a total of 511 patients, 98 of which were excluded due to their hand-assisted approach, leaving us 413 patients, which fell into the categories as listed below. Our cohort had no significant differences based on demographics between groups, which gave us a relatively equal population to compare them between. There was no difference in age, sex, race, BMI, or even previous abdominal surgeries or as ASA class. We did note that the lower tiered group did have a higher number of reoperative liver surgeries, and that the robotic group had a higher number of high-tiered Japanese difficulty scoring patients. When looking at our cohort, again, we found that the Japanese difficulty scoring system developed by Ban et al. Was an excellent predictor of intraoperative complications, as noted with a significant difference in operative time, EBL, and postoperatively, it correlated well with length of stay as well as post-hepatectomy liver failure. Interestingly, again, it failed to show a significant difference in regards to highest complication index between tiers, and there's no difference in 30-day readmission rates. There was no difference also noted between tiers in regards to mortality, but as we predicted, the comprehensive complication index was significantly different across tiers and showed that with increasing tier, there was increasing total complication burden for the patient. Overall, our study validated that the Japanese difficulty scoring system is good for predicting intraoperative outcomes, as noted previously. And we also validated that it was good for predicting postoperative outcomes such as length of stay, post-hepatectomy liver failure, as well as overall complications as noted by the comprehensive complication index. The study highlights the utility of the CCI for assessing postoperative outcomes for MIS liver resections as it correlates with the Japanese difficulty